Hello, I'm Jacob Avila of 5 Minute Sono, and I have with me a very special guest, Dr. Peter Weimersheimer, who is the professor of surgery in the emergency department and basically runs ultrasound in Vermont. Is that right?
Not quite the whole state, but
Okay.
eventually I'll be the Dark Lord of ultrasound and take over the world. That's the intent.
Awesome.
Yeah.
So Peter and I were talking the other day, and he talked to me about this amazing case that he had. And it's a case that it scares me because I feel like I've probably missed this in the past because it's kind of an atypical presentation, except when you have the ultrasound. When you have the ultrasound, it's like super obvious, but without it, I feel like I've discharged this patient home before. Peter, can you walk through the case with us?
Yeah, sure. This is I guess for me was a relatively typical case and presentation. Was a guy in his 70s, had been feeling pretty lousy for 3 weeks. Had seen his PCP, had an X-ray which was as typical for X-rays and pulmonary processes, read as whatever, and was treated with Levaquin for pneumonia. Didn't really get better from the Levaquin and came to me because he was just feeling just profoundly worse, more fatigued, more short of breath. Described having, interestingly, as we talked about with the causes, about a week and a half earlier, had a couple days of profound, like something's really wrong. And that seemed to pass, but he just kept on going downhill.
Huh. Interesting. So, does this guy have like any physical exam findings of pneumonia or anything like that? Physical exam findings of
No, not,
failure?
No, so this is clinical exam, right? He had a relatively normal exam. So maybe decreased breath sounds, bases, maybe some schmutz in it, but not really. And as we'll talk about the diagnosis later, he had none of the physical findings that really of anything. So, this is somebody basically presenting with undifferentiated dyspnea, fatigue. So my go-to is going to be grabbing an ultrasound system and start to check that out. Gotcha. So that's kind of where I'm left.
Where did you start? Did you hit the lungs first? Did you hit the heart
first?
Yeah,
this to me, I see a lot of patients who present with failure. It's a classic story. A couple weeks of fatigue, a little more short of breath, and bang, put the ultrasound transducer on, and there is failure. So that's what he sounded like to me clinically. Put the probe on his lungs. He had bilateral pleural effusions, had a B pattern. Gotcha. Everything looked exactly like expected, except then I always do if I'm doing lung, I'll always go and do the heart. If I do the heart, I always do the lung. I just like to put them together. Yeah. And when I looked at his heart, it was definitely a surprising finding. It was just that, not the norm. So I'm looking for systolic or diastolic failure and ready to go call his PCP and say, here's the disease you got and what meds do you want. I like to do that. I like to do that a lot in my practice. But he didn't have any sign of systolic or diastolic dysfunction.
Yeah, so here's the peritoneal long axis for you. And like you said, I'm not really seeing... it looks like it's pretty good squeeze. The base seems to be moving okay. Not enough to cause this failure picture that you're demonstrating. But if I look closely at this, not even closely, if I look at it from far away, this aortic valve looks really weird. Like, what's going on with that aortic valve?
As that valve hits you in the face.
He
has that small pericardial effusion, which is also insignificant. That valve has this big mass on it. It says it has a vegetation. Wow. Pretty obviously. And when I put color on it, definitely dysfunctional, a lot of regurg. Explaining the failure.
Got it. Well. So this was not, just to be clear, this is not like a 20-year-old IV heroin user. This is a elderly gentleman, right? That has fatigue and has symptoms of heart failure, but has a completely different diagnosis that's treated a completely different way. Yeah,
and I think for again, heart getting a endocarditis from IVDA tricuspid is pretty common.
Sure.
Things almost like not that exciting because we see it so much.
Yeah.
But elderly patients get endocarditis quite a bit. It's simply less tricuspid versus mitral, and aortic is pretty rare, and oftentimes no cause, nothing that would explain why they would get an endocarditis, but pretty well described. And thankfully for bedside ultrasound, the norm in the primary care setting is somebody like him who eventually gets sent for echo after cultures and the whole workup. And the reason that's been so difficult is that it's hard to get an echo. Right. We now do it pretty routinely, so it's relatively available to us to make it earlier and faster.
Sure. So now let's do a quick review on how to identify endocarditis.
You go for it.
All right, so here's just a little review. If you want a more comprehensive look at endocarditis, go to the 5-Minute Sono website and look for the lecture that I posted there a few months ago. So when you're looking at endocarditis or looking for endocarditis, what you're trying to evaluate for is what I call valve boogers. So you're looking for a little bit of a mobile mass on the valves. So if we look over here on the right side, this is a normal apical 4-chamber view. We got our mitral valve over here, tricuspid valve over here. And if you look over here, there's a little bit of something right here on the tricuspid valve. This is a tricuspid valve vegetation. So now let's look at this next image. We have that same apical 4-chamber view, but instead of looking at the tricuspid valve, let's look at the mitral valve. Let's look at this septal leaflet right here. You see how it's thick and there's this mobile, like small mass right here? This is a mitral valve endocarditis. Now let's look at the parasternal long axis view on the right side of the screen. That is NL for normal. And on the left side, we have abnormal, AB normal. And you can see a very thickened, mobile bit of a mass here on the septal leaflet of that mitral valve. This is the same ultrasound from that previous apical 4-chamber view. This is a parasternal short axis view, normal on this side and abnormal. Look at this booger, this giant valve booger that you see right here, this white thing that pops into the screen here. This is what a tricuspid endocarditis looks like. You can often see it on the parasternal short axis view, but you can see it on any view, the parasternal long, the subxiphoid, the RV inflow view, which is maybe one of my favorite views to look for tricuspid endocarditis. And it just really depends on the plane and where the valve happens to be as far as which one is best. Here is a subxiphoid view. Let's look at this normal on this side, compare it with the abnormal on this side. You see that big chunk right there? This is a mitral valve endocarditis. And finally, let's look at a tricuspid endocarditis on a subxiphoid view. Look over here on the left side of the screen. You see that mobile mass on that tricuspid valve? This is tricuspid endocarditis. So Peter, wow, what an amazing case. Endocarditis is definitely something that you should think about in your patients, even if they're not just IV drug users. This kind of almost chronic worsening fatigue, being sick. It doesn't take that much work to wheel in that ultrasound machine in there and do that echo, right?
No, it takes no work at all, really. And this is, we talk about this all the time, that you don't have to be a zealot about ultrasound, but, certainly for respiratory stuff, the x-rays and clinical exam are pretty limited.
Right.
And I've never gone home late at night going, damn, I did another negative ultrasound. Yeah, and right. Versus I went and I looked and I saw something, or even worse, I go home and go, dang, I should have just taken a look. It takes really, on a clinical scale, relatively little time, and it's really, this was a profoundly different case. Of course. This guy went to the operating room, got an AVR, did great. Mm-hmm. It probably would have happened at some point, but certainly he was on this long-term trajectory of having, worsening infection, worsening complications. So it was nice to find it.
Right on. Peter, thanks so much for joining us, and we'll look forward to having you on the podcast more.
Excellent.
Cool. All
Take it easy.
See you, man. Oh, one more thing that I almost forgot. Peter, we almost forgot to mention CastleFest 2019. We're both going to be there.
Shame on you.
Yeah, that's right. Totally my fault. We're both going to be there. The URL is castlefest2019.com. You can see us, talk to us in person, and we can talk about whatever, including endocarditis, because we kind of like it.
Yeah, we love it. And CastleFest is just a great conference.
Agreed.
Thank you guys for getting it going. It's just awesome.
For sure. Okay, cool. That's
perfect.
All right, man.
Right.
See ya.
Bye.